Thank you so much for the organizers for giving Forge the opportunity to present the clinical program that we have with FBX-101 for Krabbe disease. Well, you are experts on the leukodystrophy world, so you don't need much introduction on Krabbe. This is a leukodystrophy caused by pathogenic mutations in the galactosyl cerebrosidase gene, leading to demyelination and neuronal death. The incidence is ultra rare. This is 1 to 100,000, maybe even less. Is diagnosed either through newborn screening, and this is the case in the US. Unfortunately, in Europe, there is not such a program. Or when there are siblings with the disease, and with the new pregnancy, the child is diagnosed pre-symptomatically. The other situation, obviously, and the most terrible, is when the child is diagnosed when it has already developed symptoms. And as I mentioned before, it's important in the US, there are newer screening available in 10 and soon 11 states, covering 1/3 of the US population. The progression of the disease, and there are different subgroups. The most frequent is the infantile form, that is the most aggressive. Children develop symptoms very early on with seizures, the decreased ability to breathe, feed, loss of developmental abilities, and the lifespan is usually short, with a mean age of death around 2 years of age. Currently, the standard of care for the treatment of Krabbe is the hematopoietic stem cell transplant, very frequently using umbilical cord blood transplantation. It provides a new hematopoietic system with the white cells carrying the missing enzyme and grafted in different areas, including the brain, and provided the enzyme that cross-correct other cells that are receive the enzyme produced by the transplanted cells. Umbilical cord blood has advantages. It's readily available. It's easy to find compatible cord blood units, and the outcome is excellent in centers with experience in this type of procedure. And this is the outcome that you might expect in a child with infantile Krabbe disease after transplant. And when the transplant is provided, and it has to be provided prior to symptoms in case of infantile, if it has been shown that after symptoms develop, the outcomes are not very good, so it's not recommended. But when it is provided before symptoms develop, they increase survival and quality of life to 10 years. They also allow the normal or borderline cognitive function and development. And you see here on the right of the slide, the two. One is providing the progression with the cognitive development. You have here the chronological age. These are the developmental age on this axis. And here in gray, you have the expected normal cognitive development with the mean and +2 and -2 standard deviation. So everything within this development is normal. And you see how after transplant, children with Krabbe evolve close to the lower line, but very close to normality, with a few exceptions. This is not the case, unfortunately, for the peripheral neuropathy. And after transplant, and you have here the gross motor again with the same type of graphs, you have here the normality, and children never achieve normal gross motor development. They plateau very quickly, and then they don't progress. So when you review natural history studies after transplant, one study was a study analyzing 15 patients that were transplanted with infantile before symptoms developed. Only 3 patients were all able to walk independently. 7 of them need assistive devices, and 5 were completely unable to walk. So transplant provide improvement on survival, quality of life, and cognitive, but is short on gross motor development. And something similar happens with the late infantile form when they are transplanted, even symptomatically. So what we propose at Forge is to use an adeno-associated virus. And adeno-associated virus is a DNA vector, a single-stranded DNA vector that with different serotypes. In our case, we use the RH10. You have here the schematic of the expression cassette with the GALC gene, with the promoters, enhancers, etc., that allows the expression once the vector, the virus reaches the nucleus. So the inverted terminal repeats, allowed encapsulation, and again we are using a serotype that is particularly interesting because it has tropism for the brain and the peripheral nervous system. So what we're proposing for FBX-101 is that in the context of the transplant that provides a healthy cord blood with carrying normal enzyme, etc., as I mentioned, and in the context of the the conditioning regime that immunoablate the patient, we provide or administer intravenously the vector, the HBRH10, to target the brain and also the peripheral nervous system, and provide the additional enzyme that might be required during the life of the patient to complement what is being produced by the transplant. With this idea, there were several non-clinical studies in relevant animal models, in the Twitcher mice, in the Krabbe dog model, that provided the context, the synergism between these two strategies, the doses, the timing, etc. We conducted toxicology studies in rats in order to provide the safety profile that allow us to identify potential targets in the clinical trials, and everything together led us to an IND submission and the approval for the trial that I'm going to present to you. So the clinical program using FBX-101 consists currently of two different trials. One is called Rescue, and this is a phase 1/2 clinical study in children with Krabbe that are resilient in the context of the hematopoietic stem cell transplant, and I'm going to describe this a little bit better later. And then Reclaim is the other trial that we have for children with infantile or late infantile Krabbe that were already transplanted time ago. So one Rescue is in the context of the transplant. Reclaim is for children that were transplanted. And we try to summarize here the context of Rescue and Reclaim in the context of the disease diagnosis and outcomes of treatment. So children are usually diagnosed either neuroscreening in the US or because of family history in Europe, asymptomatic. And then they might be also, as I mentioned before, diagnosed when they are already symptomatic. Usually the basis of the diagnosis is the Galxy enzyme levels, with the second confirmation with the cycosine testing. Cycosine levels allows you to see if the child belongs to the infantile population when they are higher, or the late infantile when they are a little bit lower, the cycosine levels. Obviously, genetic testing is conducted, but it's not. It is less relevant for the definition of the patient as infantile or late infantile. Whenever the diagnosis is made, if it happens asymptomatic in the infantile population, or in any case in the late infantile, hematopoietic stem cell transplantation is the standard of care and provide benefit. Unfortunately, children, I mentioned, when they are symptomatic in the infantile form, only might be benefit from palliative and supportive care. But when you're for infantile asymptomatic or late infantile symptomatic or asymptomatic, hematopoietic transplant is provided. And in the case of the children with late infantile that are asymptomatic at the time of the transplant, they don't need any additional treatment because the outcome is really good with normal survival, normal cognitive, and most of the development. In these two other cases, then we can add and this is where we are testing FBX-101. For those cases with infantile asymptomatic at the time that they are diagnosed and they are going to receive the transplant, they enter into Rescue. If they were already transplanted, either asymptomatic infantile or symptomatic late infantile, they enter into Reclaim. So these are the similarities and differences of these two trials. The design of both trials is exactly the same. They are multicenter trials, no placebo, they are open label, single dose escalation. The administration is intravenous. There are two different dose cohorts with a lower and a higher dose defined by the non-clinical studies. Is from treatment to the last visit, there are 2 years of follow-up, intense follow-up. In both trials, there are then additional 3 years for a longer term following in order to evaluate the safety of AEVs, and this is mandatory in the US and in Europe for safety reasons. And the endpoints are really similar in both of them, with only some differences in Reclaim based on the ages of the children that are involved and the type of scales that are needed. The main differences are the age at the time of enrollment, because in the infantile in rescue or in the context of the transplant are younger. In the case of Reclaim, there are a broader age population from 3 months after the transplant to years after. The onset, obviously, in Reclaim is only for infantile. In rescue is infantile and late infantile. Symptoms status, they have to be pre-symptomatic for infantile. They may be symptomatic in the case of late infantile. The treatment window after transplant is only 21 to 60 days in rescue. So at the time where they have been transplanted, they are heavily immunosuppressed. Or in the case of Reclaim, at least they have to be enrolled at least 3 months after the transplant, with older ages, obviously, I have mentioned before. 6 patients are enrolled in rescue in 2 cohorts, 12 patients in Reclaim, 6 in late infantile, 6 in the late infantile. This is very important immunosuppression because of the transplant. There is no additional immunosuppression needed in rescue except a short course of prednisolone because the patients are heavily immunosuppressed by the conditioning regimen and then the drugs that are administered in order to prevent complications such as graft versus host. In case of Reclaim, there are a variety of cases. Children might be still 3 months after transplant receiving some immunosuppressants. Some others 2 years, 3 years after, they may be completely immunocompetent. So we have defined an algorithm in order to help the principal investigator to define the immunosuppression regimen. And this is provided to a committee that we have created specifically for this purpose with experts in transplant and in Krabbe. They review the immunosuppression proposed and they go back to the PI and accept the protocol. So this is customized based on a case-by-case basis. And finally, another important difference is that in rescue, there is no exclusion based on antibodies to the vector. They are very, very young. They are heavily immunosuppressed. So we don't expect any, at least initial immune responses to the vector. In case of Reclaim, because of the different situations where they enter the trial and the possibility that they have been exposed and they have developed antibodies if they are immunocompetent, we have one exclusion criteria based on a titer of 1 to 100. In endpoints, these are very early clinical trials. So both in rescue and Reclaim, the primary endpoint is safety. The incidence of adverse events that are related to the product. And in the case of rescue also, because this is so close to the transplant, we want to make sure that the gene therapy does not interfere with the outcome and engraftment, etc. So there is an incident of engraftment in this particular case. Secondary endpoints are very similar with the difference of the ages. So in the case of rescue, we have 2 main secondary endpoints. One is the probability to achieve independent sitting, and this is a milestone that they might achieve within the first year in the case of if the outcome is positive. The other motor outcome is the improvement in gross motor function. In rescue, we use the Peabody Developmental Motor Scale, PDMS-2. In case of Reclaim, is the same outcome, but using, in this case, the GMFM-88 because of the ages of the children. And because this is a rare disease, every patient is really valuable in the amount of information that can be collected. There are going to be only 6 patients and 12 patients in the other trial. So there are a lot of additional exploratory endpoints addressing gross motor function, cognitive or fine motor, quality of life, developmental milestone. And this is important because the family has a questionnaire. Whenever the child achieves a milestone, they include this and the date that it was achieved, and this might be compared. I didn't mention that the comparator group for this study are going to be the natural history studies that have been conducted both in children without the transplant and those that receive the transplant. So we will compare the outcome of this trial with untransplanted, but mainly with the children that were transplanted in order to see if we can provide additional benefit. Assessments of white matter and the myelination is very important. We use brain MRI and DTI. We also measure the thickness of the caudriacina in case of in Reclaim. And then we also, because they are important symptoms and signs of the disease, we look at the hearing and vision of children using behavioral audiometry, ABRs, and visual potentials. And clearly, biomarkers are extremely important. So we are measuring cytosine, so we can decrease the one of the markers that accumulates in cells and is involved with the pathogenesis of the disease. We measure cytosine in blood, plasma, leukocytes, and CSF. Clearly, we are trying to replace and provide additional enzymes. So we are going to measure galaxy also in blood, plasma, leukocytes, and CSF. And in order to see the brain, and if we can improve or reduce brain damage and improve myelination, we are measuring neurofilament light and myelin basically. Finally, we try to see what happens with the vector, where the vector is present after administration. So we conduct vector shedding studies in plasma, saliva, feces, and urine. With this introduction, I would like to present you the data that we have so far, starting with rescue. We have enrolled so far 2 children in rescue. They were diagnosed through newer screening, and they have received the same dose, that is the lower dose, 1.6 10 to the 13 viral genomes per kilogram. And there have been no infusion reactions, nor treatment-related serious adverse events through a follow-up of 12 months in one case, 9 months in the other. This is very important because in general, the safety concerns with AAVs happen either during the first 2 weeks, I would say up to 2 months, but later on there are no additional adverse events. So we have passed this period of time without changes in liver function tests that are very often associated with toxicities with AAVs, normal liver ultrasounds, and normal nerve conduction velocities. Now, DRG toxicity, that is another factor, has been described in non-clinical and some clinical studies. The first subject received the product FBX-101 24 days after transplant, and it didn't interfere. I mean, chimerism engraftment was achieved normally, and full donor chimerism was achieved later on. So, and the second, unfortunately, had to receive 2 transplants. The first transplant was successful, but due to COVID-19 infection, it lost the graft and required a second transplant. After the second transplant, 20 days after, we infused the vector. Yes? Is there any questions? Sorry. Okay. So I continue. And this is the first data that we consider relevant, is the development of antibodies to the vector. Antibodies after gene administration with AAVs rise very, very fast to very high levels, and this is what you may expect in a clinical trial. And they have been related with toxic events, thrombotic microangiopathy, liver damage, and other complications. So in the context of the transplant, as you can see here, none of the 2 patients have developed any level of. So they remain negative. I mean, there are no increase in antibody levels, and this is an important safety feature. This is something expected because of the heavy immunosuppression of these children. Important data regarding biomarkers. We are trying to provide additional enzyme in order to complement what the transplant is provided. So you see here, plasma galaxy level. You have the 2 patients. This is chronological age. The first patient received the transplant gene therapy soon after transplant. You see this very quick and fast increase that is prolonged 6 months. 3, 4, and 6 months later, and with additional increase 1 year. But this is very fast. That is also reproduced in the second child. Remember, there were 2 transplants. The first one, we measured there was no change in galaxy. Obviously, the transplant didn't graft. After the gene therapy, we reproduced this fast increase to levels that are high above the normal levels. You have here in gray, and this is still data being collected with the method that we have developed together with Dr. Michael Gelb at the University of Washington. And we see in both cases a fast and sustained to high levels of plasma galaxy. This is levels of galaxy on the CSF. Again, these are the first patient, the second, the 2 transplant. You see in both of them, and this red dotted line here represent the normal levels of galaxy in plasma. In CSF, there is a quick increase that is also sustained 1 year and 6 months after the administration. So we are correcting the enzyme deficit to very high levels on top of the transplant. And this we will translate into changes in the myelination in the brain. This is the DTI tractography for the corticospinal internal capsule fractional anisotropy on the left side on the right side, on the left side. And here you have different groups in different colors. In gray here, this is the normal DTI in children without disease. So you see higher levels of fractional anisotropy with chronological age. This is up to 4 years. And then there's an increase, and then it plateaus. Here at the bottom, you see what happens in children without treatment, and those are the ones here in brown, or children that were transplanted when they were symptomatic. These are infantile. So you see that there is no increase in fractional isotropy. There is no correct myelination. In blue, there are the children that received the transplant when they were asymptomatic. So they are below normal, but much higher than the untransplanted or transplanted when they were symptomatic. So the transplant itself provides a significant correction in the myelination in the brain. And here you have our two patients in red and black as before, and they are evolving and they are tracking very close to the normal, to the lower cases in normality, a little bit about the children that received transplant when they were asymptomatic. This needs obviously additional follow-up, but we are quite happy with the results so far you see in both hemispheres. Finally, all these changes in the biomarkers, providing the levels that are normal within abnormal, the indication that we might be improving the myelination in the brain translating to clinical outcomes. And this is remember the number I presented before regarding the outcomes in the motor development in children with the transplant. Again, this is the PDMS scale. This is normal in gray, mean to standard deviations. This is in yellow, the evolution of children that received the transplant when they were pre-symptomatic, again, the mean and two standard deviations. And you see how the two patients that we have enrolled so far are tracking within the normal gray area. So they are achieving milestone. Both children are able to walk, and they don't have any difference with a normal child so far, 1 year and 9 months after treatment. So with this summary, the impression so far in the trial is the product has an excellent safety profile. It's been very well tolerated without any treatment serious adverse events, with no development of antibodies. It has increased significantly galaxy enzyme activity levels in plasma and CSF above the normal range for the duration of the follow-up so far. Obviously, I mentioned there will be 2 years follow-up plus 3 years where, in addition to safety, they will continue being evaluated for these biomarkers. And we are this additional enzyme, we believe, is supporting normal white matter development measured by DTI, and also improve gross motor function within the normal range. Reclaim. We have just treated one patient so far with the same level of dose that I mentioned before. Obviously, they are very similar trials on this regard. The child has been followed for 60 days, and there have been no treatment-related serious adverse event or no treatment-related adverse event of any time. A meeting with the DSMB is scheduled in order to review this safety information per protocol and then allow us to continue dosing the second candidate. The information regarding the clinical trials was on the slides, and the clinical sites currently recruiting patients and University of Michigan with Dr. Mark van der Loop as the principal investigator, and we just opened Children's Hospital of Orange County with Dr. Bob Binder for rescue and Dr. Raymond Juan for reclaim. We are working to expand the program in Europe, and this is something that you will receive news later on during the year, because we are working actively in order to expand and to have a site, at least one site for rescue and reclaim in Europe. And this is the information. You have Michelle Salvo in the audience, so you can ask her any questions, but this is the email you can use, the information on clinicaltrials.gov. And finally, we would like to thank, obviously, the families, the patients first, and the families and the caregivers for their participation, the sites. Particularly, we would like to also thank Dr. Michael Gelf for the development of the assays that we are conducting for ALK-C and Psychosine, and some of the foundations that are always helping us dealing with the families and promoting the clinical trials. Thank you so much.